Welcome to Global Connections with Robert Siegel, presented by the American Friends of Rabin Medical Center. Our monthly Leaders Forum addresses vital issues facing society and the economy, real estate and medicine, technology and science. My name is Dr. Joshua Plout. I am the Executive Director of American Friends of Rabin Medical Center, AFRMC, a 501c3 national American charitable organization based in New York City. We at AFRMC represent Israel's premier hospital, Rabin Medical Center in Petah Tikva in Greater Tel Aviv, the leading institution named in honor of Prime Minister Yitzhak Rabin. The hospital is a model of coexistence, as it serves 1 million patients annually from all ethnic and religious backgrounds with the same compassionate care. Please support our mission with a donation of any amount. Join our community of friends. Visit American Friends of Rabin Medical Center online, afrmc.org, via our website and social media outlets, on Twitter and Instagram, LinkedIn and YouTube, and on our Facebook page and discussion group. Our host and moderator for Global Connections is Robert Siegel, former host of All Things Considered on National Public Radio for 31 years. Over the course of an hour each month, Global Connections features guests who Robert Siegel interviews as they explore together important issues in our world.
Thank you to our very special guests, Dr. Irwin Redlener, Director of the Pandemic Resource and Response Initiative at Columbia University. Dr. Nahid Bhadelia, Founding Director of the Center for Emerging Infectious Diseases Policy and Research at Boston University. Dr. Kavita Patel, Fellow and Managing Director of Clinical Transformation at the Brookings Institution, and Dr. Michael Drescher, Director of Emergency Medicine and Trauma at Israel's Rabin Medical Center.
And now, Global Connections with Robert Siegel.
Thank you, Josh. And today we're returning to our roots, to the issue that led to these monthly panels in the first place, the COVID pandemic. We've come a long way since our last panel on COVID this past January. At that point, we were waiting for the vaccines to start. Today, we're going to address two overarching questions. First, where do we stand in the battle with COVID? Are we safe yet? And second, what have we learned from the experience of the pandemic? What have we learned about our country, about our healthcare systems, about ourselves? We'll put those questions to our very knowledgeable panel, and we'll take questions that you can submit by using the Q&A button on the bottom of your screen. Our first panelist is Dr. Kavita Patel, who has brought both policymaking and clinical experience to the discussions of the COVID pandemic. She was a Senate staffer for Democrats Edward Kennedy of Massachusetts and Barack Obama of Illinois, and she worked in Obama's White House in the Office of Domestic Policy Issues and continues to pursue such interests at the Brookings Institution in Washington. She's also a primary care provider practicing internal medicine at a Washington, D.C. clinic. And Dr. Patel, thank you very much for taking part in this today.
Thanks for having me, Robert.
Let me take the first of those two overarching questions. In the fight against COVID, where would you say we stand right now?
Well, I think we stand kind of on this incredible precipice. We're receiving tailwinds of benefits from vaccinations, but we're definitely not quite where we would want to be in the global setting. But it's almost as if you can see, there's an option, and it's a good one, where if we can just go a little further, then we can actually see probably the largest return to a pre-pandemic life that we've seen in the last 20 months. But there's also the unfortunate path that we could choose to take, and it really is a choice, that we dive down into the cliff and it's a dark recess. And so I feel like we're right on that edge. A lot of us are waiting to see how the next months unfold. And candidly, there's a very much a kind of an American centrism that occurs. But I think all of us on this panel are pretty sensitive to, as the world goes, that's how we will do. And that is going to take more time that we might not have patience for.
Well, my next question is what have we learned? And personally, I would say, what have you learned as a physician and as a person engaged in healthcare policy about from the experience of the pandemic? And to use your image of being on the precipice, what have you come to learn about brinkmanship in American life and how we handle precipices?
Yeah, so I've spent a lot of my clinical time in various settings, but now primarily in the outpatient setting. And I would say clinically, this has probably been one of the most humbling experiences and continues to be very humbling as we're seeing people with, call it long COVID or post-acute sequelae of COVID. It's very humbling because on one hand, there's so much about diseases of all kinds. We know more than ever before, certainly when I went to medical school and trained, about cancers and about different inflammatory diseases and how we can almost offer cures for them. And yet here's COVID novel virus, and some of the patterns that are associated with it clinically we see with other viruses, but it's just such an incredibly humbling kind of experience. But it's also, Robert, not a day goes by where where I say, I don't know. And a lot of it has to do with COVID. I don't know. And it's just not something that at my kind of clinical stage in my life, I thought it'd be doing so much. And then in terms of brinkmanship, I still think that story I still think that chapters are going to, continue to be written. The initial chapters, I have seen incredible depths of despair, and I think all of us have that are speaking today. Depths of despair, times when you really think like, this is just, this is the apocalypse, this is the end. I don't understand how we're going to get out of this. And individuals, not just me as a doctor, but individuals all had these scenarios, I think, in their minds. And then what I think we're seeing unfolding is kind of this grieving process, because I'm watching not just Americans, but friends in other countries who are doing things that are more normal in social interactions, but there's some hesitancy. And it's not because they don't feel safe, it's because for so long, and biology teaches us that for so long, if we don't have these kind of quote unquote interactions with others, we lose some of our sensitivity. So our brinkmanship is still, it's one that I think can be characterized by a type of grieving process and how we do with that.
You've expressed a concern about what happens after the initial bout of COVID, that people who come through COVID after it, they've changed in some way, and not always in the same ways.
Yeah, and I wish that I knew, this is the humbling part. I wish that I could tell you and there are some studies that here's like the strong predictive probability that you, Robert, if you had COVID, here's how you would respond. But I can't put a pattern to it. And I also think that it's definitely, even people who have had asymptomatic or mild infections, it's something that plagues them, because 6 months later, if there's something unexplained, an unusual smell or an unusual sense of like their fingers and their sensations are just a little different, or their joints ache, everybody down to 100%, including myself, think it could potentially be the COVID that was 6 months before, and maybe this is causing havoc. And then especially with some of the behavioral issues we see with kind of post-acute COVID, we're seeing, I think, so many trying to see, there's so many stressors at the same time, and especially if you've had a diagnosis, and even more importantly, before vaccines were offered, kind of a rough course of illness, or even post-vaccines, a rough course of illness. Everybody wants to know, like, when will this end, or what will happen? And none of us really know.
When we spoke a few days ago, you made a very interesting observation that in the worst of the pandemic in this country, American healthcare experimented in a lot of ways. We did much, much more telemedicine, both doctors and patients. We all adapted to a new way of getting medical care. And as soon as the peril receded somewhat, we seem to be going back to the way we used to do things. It's as if nothing useful was gained from that experience. If I understand you, you think we should look more positively at what we were doing a year ago.
Yeah, I do. I'll give two concrete examples. I mean, we shifted my clinics in particular. We went 100% virtual because we had to in March of 2020. We didn't stay that way for a long period of time, but literally overnight, Robert, we had to figure out how to turn everything virtual. And by no means was it easy, but we put an infrastructure in place, trained staff, and then got our own doctors, advanced practitioners, nurses, and then patients really comfortable with using this. And Robert, I've been able to manage diabetics who work as cashiers all day during their 10-minute breaks in between, they're kind of in the middle of their workday, which would normally in another kind of pre-pandemic time would have just been a missed appointment. So I think that's one example. The second one has been being able to take care for hospital patients at home. And it's certainly something that the trend has continued, but literally overnight kind of COVID wards that could be cared for in the home setting, those are really both really important, I think, developments. And it shows us that the way we structured healthcare, paying for it, the way we receive it, is not necessarily the most kind of patient-friendly, consumer-friendly, or care-friendly. And I think we have a lot to unpack from that, and I have no doubt policymakers will be.
There's one other point I wanted you to mention. At your clinic where you work, you're seeing not just some hesitancy about the COVID vaccine, but it spreads into hesitancy about flu shots. People who wouldn't have hesitated to get a flu shot last year or 2 years ago, whenever, now they've learned to be resistant or learned to be fearful of that.
Yeah, I laugh, but in a sad way. So the kind of curse of misinformation has now spread over and spilled over into a lot of the other vaccines, as you mentioned, flu, HPV, things that literally 2 years ago, people would I would say, we have the flu shot here. It's that time of the year when, let's get your labs and let's just give you a flu shot right now, stay in the chair. And they'll say to me, no. Now I know that those vaccines, I don't need it. I have the flu and I have protection and I don't need it. And I've actually, it's certainly not the dominating commentary or feedback, but it is interestingly correlated with many of the people who do not want to get the COVID vaccine.
Okay, Dr. Kavita Patel, thank you very much. Stick around because in about 20 minutes we'll have our Q&A session. I want to turn next to our panelist, Dr. Bhadelia. She's an infectious diseases specialist at Boston University. She directs BU's Center for Emerging Infectious Diseases Policy and Research. She worked on the African Ebola outbreaks in Sierra Leone and Congo. Dr. Bhadelia, welcome, and thank you for joining us today. It's good to see you.
Thank you for having me.
I want to pick up on what Kavita Patel was just saying, because it illustrates something in microcosm that you wrote about for the Washington Post recently, that if the pandemic and the discussion of vaccines have influenced people, some of that influence has been negative, despite the pretty amazing achievement of developing, testing, and distributing a vaccine in record time. What's actually happened? How is it that confidence in public health officials seems to have, in some ways, diminished over the past year and a half?
Yeah, I think that, Robert, my big part of my job has always been a technocratic expert, right, on pandemic preparedness. And I got to tell you, in prior outbreaks that you mentioned that I've been part of, misinformation and disinformation has always been part of the fight. There are people in Ebola treatment units who would come up to me and think that I was trying to do them some harm. But the level, I think the things that have happened over the last 2 years here in the US, the level of misinformation, I think, has just blown most people away who worked in this field. And to add to that, I think that there's just been, a lot of political aspects, state-sponsored disinformation that sort of played into this as well. And then just the confusion, right? The challenge, the underlying challenge in managing novel pathogens, novel diseases, is that there's scientific uncertainty. We're learning about them while we're responding to them. And making public health policy and then doing science communication around that is always tricky. And in a fast moving global pandemic like the one that we have, I think what you've seen is the public, with the misinformation, with this changing science, you've seen just erosion of trust that just comes from people feeling like, who do I believe, right? What is real? And but the impact on immunizations is a critical one. I mean, as I wrote in the op-ed last weekend, it's a culmination of a few different things. It's not just the COVID vaccines. I think you've seen, increasing vaccine hesitancy in this country that already was increasing, the number of parents who are getting non-medical exemptions for childhood vaccinations. And in 2019, World Health Organization already had linked vaccine hesitancy as a top 10 global issue, to the point where we had seen a 50% increase in measles cases globally, including in Europe and the US, even though we had basically controlled measles in 2000s here in the US. Then to add to that, I think the politicization and the disinformation and misinformation sharing around COVID-19 vaccine, and then one last bit to this chaos, which is the pandemic itself has actually disrupted routine immunizations. WHO recently said 22 million kids have missed their immunizations. So you're creating a tinderbox, not just for COVID-19, but potentially for other infectious diseases as well.
So when I ask you what we've learned from the pandemic about the interplay between bad information, public understanding, and political behavior, it's not very encouraging what you're describing.
No, and I think that, unfortunately, if you want to ask my opinion, I think we're in the nascency of this. I think that, we've seen the impact that social media and just social media, the politicization of stuff that gets presented on social media and amplified, and this growing vaccine hesitancy, right, is what my good friend Peter Hotez would call the three-headed monster. You're sort of seeing worsening of this, but what you're likely to see, and one of the things that my center, the BU Center for Emerging Infectious Disease Policy and Research, is working on, is this idea that if we're in a nascency of a period of time where disinformation and misinformation can be used by state actors, right, in the middle of a health emergency, that is a national security concern. As you've seen actually multiple state actors contribute to disinformation during the COVID-19 pandemic. It has definitely hurt our response in trying to recover from this pandemic. And so there's an uphill battle, even as we figure out biomedical solutions and we figure out issues around equity and making sure that people can actually get access to all the silver bullets that we're hoping to create. Yeah. The disinformation information is definitely a growing challenge.
Even good information, when we consume it from journalists, is typically consumed on a local or a national basis. That is, it's pretty easy for me to see any county in America and what its infection rate is. I may know a lot more about the counties surrounding where I live in Virginia than I do about most countries in the world. Can we reach a point, since we think locally, can we reach a point where the U.S. is safe from COVID-19 and the pandemic rages throughout much of the rest of the world?
No, and I think my very good friend Dr. Patel actually just mentioned that as well, which is that you can't, and the reason why is because so what we're doing right now is building a fortress of boosters, right? If we're saying that so currently 50% of the world has gotten one dose of this vaccine. Only 5% of countries in low-income areas have gotten, of the population's gotten a dose. So you're looking at 2022, 2023 to try to get coverage in most parts of the world, which means this ongoing potential threat of variants, the evolution of this virus continues. And so the only way we stay safe, by the way, is continuing to boost ourselves or continuing to try to vaccinate the rest of the world while we boost ourselves.
That makes sense to me. Although you worked on Ebola, I mean, why wasn't there an Ebola epidemic in the United States? Why didn't the disease cross oceans and plague all kinds of countries? Why did it stay in Africa?
Great question. Some parts of that just has to do with the virus itself. As high as the mortality is with Ebola virus disease, it's really actually hard to get Ebola. You'd have to have close contact, and even when there is examples potentially of like droplets, it's very close contact with a person. Here, this was a disease that unfortunately was almost seems to have the perfectly hit the pulse of our weaknesses, which was that it is something that's transmitted asymptomatically before you might get symptoms, or even if you don't get symptoms. So you can't catch it the way you would, pick up people who have the disease more quickly just based on symptoms themselves. The fact that it is transferred or transmitted by the air, and the fact that just because there are people with this disease who may have no symptoms, they don't see sort of the devastation potentially of people who may lose multiple members of their family and might have longstanding sort of ongoing impact from the recovery itself. So convincing people to take a unified action on this has been difficult. The tougher part of this almost is that because it's a disease that doesn't have the highest mortality, just the fact that it makes more people sick, but for lack of a better term, without actually having higher mortality, it's more likely to overwhelm healthcare systems. And I think that's what's made the burden so much higher for us here.
Dr. Bhadelia, stick with us because we'll have the Q&A session coming up in a moment, but thanks. And we turn now to Dr. Irwin Redlener of Columbia University's National Center for Disaster Preparedness. Dr. Redlener is a pediatrician by training. He's also the author of the 2006 book, Americans at Risk: Why Are We Not Prepared for Mega Disasters and What Can We Do? In that book, Dr. Redlener imagined a variety of disasters and how the U.S. would respond to them, underscoring our unpreparedness. And one of those scenarios was a deadly pandemic. Dr. Redlener joins us from New York. Welcome once again to Global Connections. And let me ask you for the score: U.S. healthcare versus COVID. Who's winning? Where do we stand?
I think we're kind of at a tie score here, and probably the top of the fifth inning. Mm-hmm. Is that a stretched baseball analogy? I don't know, but
it's out of season already, but that's all right.
A weird thing happened recently, Robert, which is that a former FDA official, Director Scott Gottlieb, predicted that we'd be done with COVID by early January, if I heard it correctly. Yeah. And I almost fell off my chair, frankly, because I'm not sure what evidence he's looking at, but I think there was kind of a preposterous overstatement and over-optimistic sense of where we are. There's just too much that we don't know. Dr. Patel talked about this earlier. We're just in an absolute world of uncertainty about what we're actually dealing with and where this is all going. And I think what we have to understand is that, well, take right now, the question is, are we about to enter a new surge? I think we are. We're in the winter season where we're going to have who knows what effect of the cold weather on the virus replication and transmission, but we're also going to be indoors a lot more. We're going to be gathering together for family and friends, holiday events, and so on. And we have all over the world, and as both doctors, Patel and Bhadelia, have been saying, that we have these pockets where the world is really under-vaccinated. It's actually frightening how under-vaccinated so many countries, not countries, continents are, which then become brewing grounds for the development of new mutations, new variants, and so on. And this leaves us in a very precarious situation because we don't know what's coming. And there's no way to wall off what's happening in countries in Africa where the vaccination rate's less than 5%, let's say. It will inevitably, anything that happens anywhere in the world is going to get everywhere in the world, ultimately, if it's transmissible enough. So predictions about the demise of COVID are premature. Mm-hmm. I think that's twisting some kind of Mark Twain.
Reports of its death are greatly exaggerated, yes.
Yeah. So I think that's where we are. We're doing the best we can, but until we get everybody at a level of vaccinations that is way, way higher than we are now. We have over 100 million people now who are not vaccinated in the United States, and we've got a big, steep climb here ahead of us as we go forward, Robert.
You've been writing and thinking about unpreparedness for several years now, so you didn't enter the age of COVID naively about how we'd respond to it. I'm just curious, despite that, what surprised you and what have you learned from the response of the U.S. to the COVID pandemic?
Well, what I've mainly learned is that the potential intrusion of raw politics into the addressing and solving of a massive public health conflict is so much worse than I ever would have imagined. Even when I wrote the book in 2006, there were obviously political forces, work there always are, but we've taken this to an extreme, thanks to Donald Trump and his followers, that have put America in danger and have basically killed a lot of us. We're at a time when, I think we're eventually going to get to 1 million fatalities from COVID before we get control of this, maybe more than that. But why is that? Why do we have governors in Florida and Texas and elsewhere implementing policies that are absolutely detrimental and really contra to the necessary policies that we'll need to get the vaccine, get the virus under control? So this is politics at its absolute worst, Robert, and I'm flabbergasted that Americans have accepted it as much as we seem to have.
But yes, and one way of describing what you've just spoken of is that instead of hearing what the head of the National Institutes of Health has said about this, or what the CDC says, well, that's one point of view. On the other hand, a guy with a radio show knows of a guy who's seen something on the web that says this, and completely untested ideas are put in the hopper equally with what we hear from people who are actually quite expert in these fields. Is it the problem that Dr. Patel described, that because it's novel, you doctors have to say too often, I don't know, and that erodes confidence?
Yeah, you don't want to, it's like you think of yourself with a serious illness, you go to your doctor. Do you want to hear the doctor say, I really don't know what's the matter with you, nor how to treat you? It's not exactly what you'd want to hear from a doctor that is trying to take care of you. But the other problem is that these horrible non-facts, misinformation about COVID, in addition to being promulgated by, really extremist radio hosts and others, we have football stars. I'm thinking of Aaron Rodgers and his recent widespread points of view that are completely incorrect about COVID have actually, accelerated the transmission of misinformation that a lot of people have believed to be the facts. It's really a shame, and I don't know what it's going to take to control all that, but I hope we're finding some keys to doing this. And basically, the message is simple for patients and for the public. We're not certain entirely, but we know a hell of a lot more than some of these radio hosts and football players who are promulgating, basically BS. And go to your doctor, go to the CDC website. There are sources where you can get accurate information. It's just that people seem to be depending more and more on these outliers and promulgators of misinformation.
Are people getting good political messaging now from federal officials?
I was afraid you might ask me that. They're getting good information, but is it consistent information? We have, we're still kind of trying to get our messaging correctly expressed to the public. We've had some missteps, CDC, to be frank, where we've said something, we've heard something from the CDC that was reversed soon after. All these things tend to erode public confidence in the messaging, and I think we're getting our act together now. But I'm pretty sure that in terms of the basic policy recommendations, every person, every federal agency that's dealing with this can agree that we need to get people vaccinated, that we need to maintain the other public health guidelines as best we can until we get this thing under control.
Dr. Irwin Redlener of Columbia, stick around. We'll have the Q&A session right after we hear from Dr. Michael Drescher, who joins us right now from Israel. Dr. Drescher runs the emergency department at Rabin Medical Center. He also sits on the management team for epidemic advisory group to the Israeli Health Ministry. Israel has given us throughout the past year a glimpse of the near future. It closed off its borders. It has only one international airport. It did so rather promptly and effectively. It tested very quickly. It vaccinated early, being very well supplied by Pfizer. So we've checked in with Mike Drescher on occasion to hear what's going on there. Welcome once again to the
Thank you,
program.
Robert. It's good to be here again.
So let's start with the end of a pattern. Israelis were always taking steps before the United States did, but when it came to vaccines for young children, Israel hesitated and actually took longer than the U.S. did. What was that discussion like in your?
Right. Well, as you remember, when the idea of the booster first came along and the waning of the immunity of the first two vaccinations, the Israelis were really at the forefront of getting the booster out to the public, and actually reported to the FDA to influence and to have an impact on their decision. When it came around to making the vaccine available to children, there was really a sense of let's wait and see a little bit more. The risk-benefit ratio being lower, the questions, the sensitivity, even the logistics of getting children vaccinated versus adults all made it seem that it would be worthwhile to wait and see what the experience was in the U.S. And shortly thereafter, in fact, last week, our committee recommended, and the Ministry of Health adopted yesterday or the day before, that little kids from ages 5 to 11 can be immunized.
Generally speaking, has life at the emergency department or at Rabin Medical Center, is it back to normal now? Would you say this is what it was like before COVID?
We are getting quite a lot back to normal, I would say. We had COVID and we didn't have patients. That is, we had sick COVID patients, but the rest of the patients were staying back, so our census were down. Then the COVID seemed to go away for a while, and so we had patients without COVID. And then we had COVID and a surge of patients because people weren't afraid to stay away from the department anymore, which was actually good because during the time when people were staying away, they weren't getting their general other medical conditions, emergencies taken care of. We did see people with delayed care of all sorts of conditions, including heart attacks and strokes, because they were afraid to come to the hospital in the initial phases of this disease. And now with the end of this last fourth wave, the kind of the Delta wave, which seems to be pretty well on its way out, we are more or less back to, we're also back to normal in the sense that we know how to take care of this now. We're much less, we have our routines down, and people are much, not to say that people aren't burnt out from dealing with COVID over the past 2 years, but I think both the numbers are more manageable and our routines are more down.
Israel is a country that is a destination for tourists, for pilgrims of various faiths. Young Israelis are known, especially after their military service, to go off and travel through the Himalayas or through some points east. It would seem to be a country that can't seal itself off from the rest of the world and from countries where rates of vaccination might not be very high. Is it back to a fairly normal rate of travel, visitors coming in, Israelis going out?
It's getting there. In terms of Israelis traveling, yeah, the restrictions have been reduced. In terms of people coming into the country, it's still very much being done in a limited manner. Only right now, as we speak, kind of groups of tourists are being allowed back in the countries as groups that can be kind of more monitored and taken care of. So while you're right to say, you mentioned the fact that Israel's main port of entry is one airport, not exclusively, but for all practical purposes. So it makes it much more easy. And we have once upon a time, our southern border looked like the US border at some time. And now there's a very strong fence along that border. So there's virtually no ability to get to come through the border. So Israel does have an ability to seal itself off, but not hermetically. And certainly there is going to be, whatever happens in the world is when the next variant comes along, we're going to have to deal with that sooner or later, just like everybody else.
And for you, if I ask you what have been the lessons learned from the experience of the COVID pandemic in Israel, what would you say?
Well, I would say two things. First and foremost, as an emergency physician, was, as I mentioned before, that when people become singly focused on one thing, a lot of things can fall by the wayside. We heard about Dr. Bhadelia about the decrease in general vaccination. Well, that's a terrible thing. Also, people came in late with their heart attacks because they were afraid to come in, or they haven't gotten their cancer screenings as they should have. And so this is one thing, is that we need to maintain we need to be focused on the disaster at hand, and yet we also need to maintain our focus on the rest of things, because sometimes we can be doing more harm than good. And the other thing is just, what is the right answer, the right kind of more economic, social answer to this pandemic? And that this last wave, the Israeli government's managed to keep the country fairly well open, and that's been a huge boon. And we look at at Sweden as an example of another country that exactly the same population, much older population, and they had a very different kind of socioeconomic approach to what a lot of places did. And it's very interesting to see. And in some ways, they've come through this a lot healthier than a lot of places. So those are the two major things that I think that I look at. And there's plenty more, but I'm sure we don't have time for all that.
Well, we have time to discuss what all of you have said. Mike Drescher at Rabin Medical Center. We're now going to be joined by all of our panelists, Dr. Irwin Redlener, Dr. Nahid Bhadelia, and Dr. Kavita Patel. Let me put a question to you that's been submitted by, this is from Karen and David. The unprecedented mobilization of huge intellectual and physical resources that resulted in the life-saving vaccines. Why can this energy and resource not be applied to other serious diseases such as cancer? They ask. Are they applicable? Who wants to try that one? Is the comparison apt? Dr. Patel?
Yeah, it is apt. My former boss, Ted Kennedy, spent much of his life kind of working on legislation to boost originally research in cancer, and eventually, before his death from cancer himself, kind of a moonshot for cancer.
Yeah.
And if you look at what was part of that, it obviously just, we still have problems with cancer. So I don't want to make it sound like that was the solution, but that's also been, I think, a foundation for so much of what we have in the FDA, the NIH, a lot of our regulatory and research efforts. However, I think, Robert, it's very fair to say that nothing like a global pandemic where everybody has mutually beneficial interests, including pharmaceutical manufacturing companies, to actually kind of go all in. In the United States, this would not have happened with like the pairing of the private sector with public funds. And so I think that if we were to think about kind of analogies, and I think Nahid, I think everybody else on the panel is probably better equipped to talk about how they are applying some of this in other infectious disease areas. But we think about, even, Robert, why not use this to tackle diabetes? Why are we, there are diseases, obesity. I mean, there are things where we're, again, still kind of right on the edge, and people still are dying and suffering from heart attacks. And so I think that this is the example of what could we learn from this. And unfortunately, we're not going to be able to do everything for all, and cancer is not one disease. So I've thought about this before, but I think the incredible development of messenger RNA technology, which has been used in cancer treatments, can be advanced in such a way that we can actually make those more accessible and cheaper. That much we've learned, and I think we can do a lot more there.
Okay, here's a question. This person writes, my son is a university student trying to have a normal social life, but some of his friends are testing positive for COVID, though they're all vaccinated, and some even with boosters. What advice should students at college and public schools follow to minimize their exposure? So, Dr. Bhadelia, you're working at a university, so I'll let you try to answer that question.
Yeah, and I'm going to dovetail a little bit about the prior question as well. I was going to say the other benefit, the mRNA technology is certainly one part of this that's now being applied to really infections that are killing hundreds of thousands of people annually, right? Tuberculosis, malaria, for example, mRNA is now being applied to malaria. And so you are seeing benefits of technologies being focused on endemic diseases that are keeping entire regions of the world in a disease poverty trap. And all it's taken, as Kavita was saying, it's shown that you actually just need money and commitment to be able to make moves in a lot of these things. To your point, and the very important question, which I think many university campuses are now tackling, is that what we're seeing is, once you've had once you've been vaccinated, the vaccines themselves decrease your chances of infections by 5 times, the chances of hospitalizations by over 10 times. So this is already a group that is lower risk than what you're seeing potentially in patients who are 60 years of age. With the vaccines, I think you've decreased their chances of severe disease. But of course, as the Kavita mentioned at the very beginning, the remaining risk remains. You still don't want to get yourself in a situation that you don't want to get COVID, because there's still circumstances of COVID or after effects of COVID that we don't understand, and long COVID is certainly one of them. And we did a study looking at survivors of SARS-CoV-2 convalescents, and we saw exactly that. We saw immune changes in them even 8 months out compared to pre-pandemics, and so there is something that happens. The way that universities have sort of looked at this is still having testing on board available, and that's one way that we've made sure that there is the students are able to pursue some social gatherings, reducing opening up like dining halls but reducing the number of people in any one space, encouraging social sort of interactions, but making available all those other tools, including maybe improving ventilation, decreasing or decrowding a little bit, at least to sort of avoid that, and then making sure that everybody's vaccinated. That's really been the biggest this semester. This is the way that many universities sort of handled the return to normalcy.
But Irwin, Redlener, if someone were to ask you, plain and simple, I want to go to an NFL game, and it's going to be packed. I'll be one of 65,000 people watching the football game. From what I see on television, masking doesn't seem to be common in that environment. Do you say it's all right, it's out of doors, or the dome is very big, or do you say no, I wouldn't do that? I would recommend against it, or do you not have an answer as a doctor to that question?
Yeah, so this is it's a tough question. It's a practical question. It's a question that I address with my senior at the university grandson, who goes to football games. He goes to fraternity parties, et cetera, et cetera. And I'm, basically freaking out. And I'm saying, hey, man, you have to take care of yourself. Yes, you've been immunized. And this guy's really a great kid. He's smart. He himself dealt with a cancer that is cured, but he's been vaccinated and he's gotten a booster shot. Yet he has several of his pals that have gotten, a breakthrough case of COVID. And like, Nahid and Kavita have said, we just don't want to get enough. We don't want to get this disease, even if it's a breakthrough that may be less severe acutely. They'll have all kinds of potential long-term effects that nobody wants to have. So the idea is that we should get vaccinated, number one. Number two, we should make sure that people are following common sense rules about not crowding any more than is absolutely unavoidable. And there may be times where they don't feel safe. If you're in an indoor stadium versus an outdoor stadium, that's different. But I think the big thing for university and college students, Robert, is education. Education. Get the messages out to the students very straightforwardly, not hysterically. Listen, we don't want you to get sick. Here's what the facts are. Here's what can make you sick, and here's what's unknown about it, even if you've gotten vaccinated. And I think the more we push that, the more we make that information available, the better chance we'll have of those young people making the appropriate and smart decisions. That said, it's very tough. I think we all remember being in college. I sort of vaguely do, but a long time ago. But you're not exactly subject to high-minded, rules and guidelines put out by the dean's office. So, but there are other ways of communicating with college students, including peer communications, which I think could be very important as well. But I think that's the best I can do with this one, Robert.
Okay, but the mention, Mike Drescher, of breakthrough infections, which we're talking about people who have been vaccinated, they've gotten the 2 shots, maybe they've gotten even a booster shot, but then they still get an infection. I remember when we spoke, you had just gotten your booster, and in Israel, and we're still talking on this end about what age to start giving boosters. Is the message of breakthrough infections that maybe we have to become mRNA dependent, that we have to keep on taking booster shots more often than even 1 year because it peters out after 8, 9 months. I mean, what?
Well, I don't, Robert, I don't think we know yet. I mean, there are shots that you take two, and then the third one lasts for a long time. You know, hepatitis B is a very good example of that. That the two shots don't really do the job, and then the third one lasts for a long time. That's not, you know, they're not parallel vaccines in terms of how they're produced, et cetera. But they, you know, so we don't know yet. There's a combination of things. You know, if everybody gets, if there's a large amount of immunization or a large amount of just people being ill and recovering, this may die down to the point where the level of vaccination that you have is good enough for the time that we need it. And it also may well be that, you know, every year we get a flu shot, and we may need to get every year a combination flu SARS-CoV-2 shot. That may well be in our future. It's part of living with this. I don't think it's going to be, I think we'll set ourselves up both for disappointment and for bad policy if we wait to say that we're going to wait for this to be over with before we get back to living our lives and doing what we need to do. We need to learn how to reasonably and safely, as best we can, live alongside this pandemic, which will maybe become an endemic.
Well, here's endemic, meaning it would be with us generally all the time, but not in these incredible spikes, I guess. This is a question from Mindy Mitchell. Since it's highly unlikely that we will ever be without COVID-19, how can we communicate about how to live with it? Let me ask Nahid Bhadelia to try that one. And what's the we've heard various people try to talk about this publicly, and well, what would you say?
I'll start by saying when people say, and I actually completely agree with Michael, is that I think that we're getting to a point where we have to figure out what not yet, not necessarily going into the winter surge, but soon, as we get more, there are parts of the world that really get really high vaccine coverage, as Israel has. We have to think of what it means to live alongside this crisis. But the fact that this disease has become endemic to begin with, it doesn't mean it disappears. I think people in the general public are looking at it and thinking, okay, that means we go back to normal. Look, it's endemic. This is it. We got to stop thinking about it. What it actually means is that your life has now been layered with a brand new risk. And as Michael said, this means either we combat that by vaccines or we combat that by, making sure we diagnose and identify vulnerable folks and get them into treatment. But the easiest thing to capture is that it becomes endemic in some ways, and we're able to live with it when our healthcare systems are no longer threatened to be overwhelmed. That we are not going to go through these seesaws where we can't really predict how and when we will be able to take care of people with other diseases, that we stop being overwhelmed, and not just here in the US, but I would say globally, right? I mean, the impact on this in many communities that are going to continue to see this seesaw for a long period of time until we vaccinate them is going to be important. So that's one. But two, it's this idea that I think probably every society, every country will have to make a decision on itself, which is, what is that off-ramp? What is that risk acceptance? And I think in some countries, it's going to be a more heartbreaking decision than in others. If you're a country, the poor country that's been heavily affected by the economic lockdowns that's happened, you still don't have access to vaccines. I think you might see a year down the road where a majority of your population has now got natural infections. The decision you're going to have to make is, okay, when do we consider what's endemic or not? Because people are dying of many other things as well. There's some heartbreaking, the decision of off-ramping is actually a lot more heartbreaking and harder than most people realize it's going to be.
This is a question that a viewer submitted. I wonder why antibody tests are not more readily available. Isn't it so that some people may need boosters and others not? Or would you tell from Dr. Patel, would you learn from antibody tests? You have to unmute yourself. Well, there you go. Could you learn from antibody tests whether someone is more likely to need a booster shot than not?
I mean, you can certainly learn from antibody testing, which we can do now, whether someone has had the infection. And we do know that if people have had the infection, that plus a vaccine almost makes you, kind of the most super protected person possible. And so that's a helpful correlate. Plus, I think it would go further in some of the concerns that people have had about vaccine mandates. And because some countries, for example, Italy, use natural infection as meeting the criteria for being immunized. I think there are some flaws in that though. So I'll say the viewer asked the right question, like, could there be like more rapid access to these types of tests? And I think the short answer is yes. And the longer answer is much like our country has been suffering from having like a plethora of PCR tests or readily accessible home tests.
Yeah.
There are things that have, we've got ships off the port of Los Angeles that are not able to come in, and supplies in the chain that can't meet some of these demands. So even if we had these tests, I think we'd be facing the next clinical question, which is what is the correct amount or antibody level that correlates with the kind of protection that means you don't need a booster, or that you are at the same equivalent of someone who's immunized. And we don't know over what period of time that wanes. So we're talking about kind of serial antibody testing. So yeah, it's a little more complicated.
Yes, it is. But are you saying that in Italy, if I had not been vaccinated, but as indeed I did, I had a mild case of COVID, that would qualify me among the. I could be like Aaron Rodgers. Then I could say,
you get a green light.
I'm immunized. I'm immunized. I could say.
Now, Italy's government has the Ministry of Health has basically stated that they have the right, as the United States does too, to kind of reevaluate what those goalposts are. And I do think that with time they will change that. But the combination of kind of so many people in Italy being infected, plus I think also just availability of vaccines, force the hands of the country. And it's not the only country, by the way. So there are, and I think that's why the United States was put under some pressure to acknowledge natural immunity, to fulfill criteria for being fully kind of, immunized or protected. But there are flaws with that. And we're starting to see that in countries where they have not had even vaccine rollout or even boosters to that point.
This is a question that uses a phrase I haven't heard in months, actually, which is by what date, the viewer asks, will America achieve herd immunity? Dr. Bhadelia, your field is infectious diseases. We used to hear a lot about herd immunity. And Mike Drescher talked about Sweden, which I think their policy was based on the idea of herd immunity, if I recall it. Is that a meaningful concept? And in this case?
Yeah, the one thing that I'll start by saying is that people think of herd immunity as a finish line. We get to it and we're done. And that's not what it is. It's actually a level of stasis in which there's enough people who are vaccinated or have immunity that the disease doesn't transmit. And that can go up and down. I mean, measles is a perfect example of this. You need 95% of the population vaccinated with measles. And then we've seen outbreaks of measles because you've lost herd immunity to that disease locally when people stop vaccinating their children. That means it's not you reach a finish line. It means you have to continue to maintain that balance or that stasis. The tough part with COVID has been that, it's thrown us for a loop because the virus itself has changed. It's become more transmissible. And the idea of getting a population level immunity is dependent on both the pathogen itself, how transmissible it is, and how effective vaccines are. And what you're seeing, and particularly if you think with natural immunity as well as with vaccines, as Kavita and others have talked about, that you might see over time waning of protection. Then it's really we just don't know. It's one of the questions that we don't know the answer to. When will we reach the stasis with COVID-19? Mm-hmm. My sense is it will be a while. You'll achieve it probably in some communities that have high levels of vaccination and maybe even get boosters. You may achieve that, but it won't be a universal thing in all places at all times.
I just have a question for the practicing internist, Dr. Patel, which is you've had this conversation with patients about you should get a vaccine. I don't think I want to do that. How does that conversation play out now? What do you hear? What's the reason for the hesitance that you encounter or that your colleagues encounter?
Yes, 3 still very common reasons. Number 1, it hasn't been around long enough, and I'm a woman of reproductive age, and I don't trust when people tell me it won't have an effect. Number 2, that usually these are people who have had the infection and they see this as superfluous. That's actually becoming, as time goes on, it's actually unfortunately a larger number of people.
Or they may be Italian, as we've
They may
learned
be
today.
Italian,
Yes.
yeah, exactly.
Right.
My very strong Italian contingency in Washington, D.C. And then the third, it's really interesting that there's I see mostly Latinx patients and Latina women, and they actually say that it's something that their faith has said that they should not have. And so this is where that misinformation, WhatsApp, kind of these incredible social networks, which have now propagated the notion that you just, you don't need this for a variety of reasons. So
Right.
good news is that, Robert, if you chip away at this and you just kind of you have to stay calm and you have to kind of keep going at it. At some point you strike, because at some point somebody's grandmother is hospitalized, or at some point, sadly, all of us have been touched in some way, probably all of us on this panel, and it does strike a nerve, and that's the window, and that's when we try to get them to receive the vaccine.
And Mike Drescher, do these conversations sound familiar to Israeli doctors?
Yeah, for sure. There's a movement of skepticism. I mean, I don't think it's a dominant movement, and in my practice, it's uncommon for people to have principled reasons for not getting vaccinated, but it's certainly there, and it has its own organic life to it, its own heroes and villains, and its own mythologies, and its own reasonable questions as well. I mean, people do have a right to ask questions about new things, but I would say that it exists. It's not a dominant, it's not a predominant kind of ideological issue in the patients I see.
Well, I'd like to thank all four of you for taking part in this panel discussion today. Dr. Michael Drescher, whom we just heard from Rabin Medical Center, Dr. Bhadelia from Boston University, Kavita Patel from the Brookings Institution, and also from DC Clinic, and Irwin Redlener from Columbia. Thanks to all four of you for a very interesting discussion of where we stand. I'd also like to express lots of thanks to Joshua Plout, Nate Bonzani, Roni Giuliano, and Sarah Lipoff from the American Friends of Rabin Medical Center, and also thanks to our technical director, Sam Lunetta. Our program sponsor is the American Friends of Rabin Medical Center. It's a 501c3 charitable organization in the United States. It represents in this country Israel's largest hospital, Rabin Medical Center in Petach Tikva, which is in Greater Tel Aviv. The group's website is AFRMC.org. Join us next month for Combating Anti-Semitism's Resurgence with guests Kenneth Stern of the Bard Center for the Study of Hate and author of The Conflict Over the Conflict, the Israeli-Palestinian Campus Debate, Dr. Sharon Nazarian, who is Senior Vice President for International Affairs at the Anti-Defamation League, Professor Ira Foreman, now of Georgetown University, and author James Carroll, who wrote a great book called Constantine's Sword, The Church and the Jews. I'm Robert Siegel. This has been Global Connections, Navigating the New Normal. See you next month. Stay healthy and stay safe.